Hi, this is Pat Williams with Your Health Matters show with Dr. Benjamin Bryant, who is Chief of Staff and General Surgeon at UH Conneaut Medical Center here in Conneaut. And Dr. Bryant, how you doing today?
Oh, can't complain, although I'll tell you, I'll be very happy when the construction at the corner of Parish and 20 is completed.
I agree with you. I agree with you.
It took Dr. Serels 5 minutes to get
one block.
in,
Yeah, I
block,
know.
and then we had a hang up getting out. And
Sure.
so
Yeah.
it's in a good cause, obviously.
Yeah, it'll be fine once it's done.
It'll be
And my
nice.
wife asked me the other day, when's it going to be done? I said, I really don't know. I think it's not going to be too much longer.
Can't be, although I see big pipes out there by the side of the road, that means digging and,
Yeah.
so
Yeah.
it's not going to be overnight, I don't
And
think.
Doc, I know you're from the Michigan area, really.
Oh, yeah.
And so you're probably, the snow they're talking about coming this weekend probably doesn't bother you that much.
Well, no, I grew up with it. I'm from Western Michigan, and it kind of changed through the years. When I was young, we would get 2-3 feet on the ground.
Yeah.
That stayed routinely.
Right.
Yeah.
So, well, hopefully that won't happen here. Now, you have a guest with you today.
Yes, we're very pleased to have Dr. Anna Serels with us. She is with University Hospitals. She's at UH Geauga, and her specialty is rehabilitation medicine. She's going to be talking to us about that a little bit today.
Excellent. Maybe you could tell us a little bit about your background, where you're from, and all that sort of stuff.
Sure. I grew up in Boston, actually, and then I was there until college. For college, I went to McGill University in Montreal. There, I stayed there actually for about 8 years while I was in school. I did a little bit of graduate school as well. And I had my first child there, and then I went to medical school actually in the Tel Aviv, New York program at Sackler School of Medicine.
So that was in New York?
There was 3 years in Tel Aviv, and the last year was in New York for the clinical rotations.
Uh-huh.
After that, I matched into a residency program in Boston in the Harvard system. For my first year, I was doing general surgery at Beth Israel Deaconess Medical Center, and then I went on to do my residency in physical medicine and rehabilitation at basically all the Harvard hospitals, MGH, Brigham and Women's Hospital, and Spalding Rehabilitation Hospital.
That's a very high-powered program.
That's a really
Yeah.
good resume there.
Woo. Wow.
So, how long you been with UH?
So with UH, I started in September. I actually just moved here in August from Boston. So I'm no stranger to the snow either.
That's right.
Boston got pummeled.
We had 104 inches, I think, last year, which is a regular Montreal winter. But I like the snow,
Yeah.
but
Mhm.
it's
Yeah.
okay.
So you have family that has moved this way?
Yeah, my sister moved here about 10 years ago, and I used to only see her about once a year. And when I was looking for jobs after my residency, I was considering Cleveland just to be closer to her, and now I see her all the time, and it's been great.
Oh, that is great.
It
As
is.
the years go by, that gets more and more important.
Yeah.
Yes, it does. It really does. Now, do you always want to be a doctor?
I always wanted to be a doctor, probably since I was 4 or 5 years old. I'm one of those.
That
Yeah.
young?
Yeah.
That's the way.
There was never anything else in my mind.
Wow.
Yeah.
Wow. So, tell us what you actually do now in your particular profession.
So I'm a doctor of physical medicine and rehabilitation. We are called physiatrists. That comes from the word physical. So just like you have a neurologist or an internist or a gynecologist, we're called physiatrists. Most people know us in the setting of rehabilitation hospitals. Let's say you have a patient who's had a stroke or a traumatic brain injury or a spinal cord injury or an amputation. They're in the hospital for maybe a week or two, but then they go to a rehabilitation hospital because they're not quite ready to go home. So they can spend anywhere from a couple weeks to a couple months in this rehab hospital, and we are the doctors at that hospital managing all of their medical needs and their rehabilitation needs. But then there's physiatrists like me that work on the outpatient side. I don't work in the inpatient rehab hospital. I work in an outpatient clinic, and I have patients come to me for appointments for whatever issues that may be bothering them. What are those issues? I see a wide variety of patients. Basically, the bottom line is that it's anything that is affecting your quality of life or daily functioning related to injury of your muscles, bones, or nerves. So
That's very broad.
yeah, that could be anything really. That could be a sore ankle, your knee hurts, your back hurts, your neck hurts, numbness and tingling in your fingers and your toes, sudden weakness, you don't really know what's going on, you can't move your leg as well as you used to. Or maybe you were in a car accident last week, you got discharged from the ED, you're okay, but you sustained a mild concussion and now suddenly you can't think straight, you can't remember things, you're having trouble sleeping, you're having headaches, and your quality of life has really declined since then. So you can come to me and I can help you get back to your baseline as much as possible.
What would you do in that particular circumstance?
So, we have to optimize sleep, make sure you're sleeping well. Maybe you need a medication for sleeping. Maybe you need medicine to help you concentrate a little bit better. Maybe you need, if you've had a more serious brain injury, maybe you need some cognitive therapy, some speech-language therapy. In the cases of more severe brain injury, you might develop some spasticity or weakness of a certain side. We can help you arrange therapy, occupational therapy, physical therapy. I do Botox injections for spasticity as well.
Oh, wow, that's great.
And I also manage intrathecal baclofen pumps in the case of diffuse spasticity.
Wow. Okay, that's great.
Yeah, and then other things I do in the office is regular joint injections, steroid injections into the shoulder, knee, hip areas. I do EMGs as well. Sometimes your doctor may prescribe an EMG or nerve conduction study test to see what's going on in your hands and legs. I do those
This is a
things.
lot more in-depth than I realized.
Yeah.
That's terrific. So it's not necessarily true that all of your patients arrive having previously been through an evaluation and been diagnosed. Like, for example, if somebody comes in and let's say they have Parkinsonism, or let's say that they have already sustained, like for example, you hear a lot about football players now and concussions and so on, and I would think that in a lot of cases they, because a lot of these problems are acute, they would get an acute evaluation, maybe in an emergency department with the appropriate specialties and so on and so forth, and that all has taken place before they come to you, but not necessarily.
Not necessarily. I can see patients who have seen many, many different kind of specialists, and all the other specialists are kind of at a roadblock and don't know where to go further. So they would send them to me to help the patient kind of move forward, knowing these disabilities and impairments that they are suffering. Or the patient just went to go see their primary care physician, something's bothering them, and then I would be their next step if the primary care physician knows that I'm here. So I try to tell the primary care physician to think of me as a stepping stone before a surgeon. For example, if a patient has knee pain, oftentimes the primary care physician will refer right to the orthopedic surgeon. The surgeon is a surgeon. They want to be operating in the OR, and their clinics are very busy. And most of these patients don't need surgery, and also they don't want surgery. They want to try conservative treatment first. So the primary care physician can refer to me. I would do the workup. If imaging is necessary, I would get imaging. Conservative measures like medications and therapy would be tried first. And then in the end, if I feel a surgical consultation is warranted, I would have no problem referring. But the surgeons, I've spoken to many here, are very happy to have me see these patients first.
So if somebody comes in, for example, and they've had hip pain,
Yeah.
and it started, wasn't too bad, gradually got worse, and now it's to the point where they are forced to admit it really does affect their ability to walk, okay? Maybe they've seen their primary care doc, they've talked to them about it, maybe they've been put on anti-inflammatories, that sort of thing, but they have not seen an orthopedic surgeon yet,
Yep.
okay? So they would see you to do the evaluation.
Yep.
I mean, if you saw bone on bone, that sort of thing, you'd probably refer them. But you do that evaluation?
Yes, I do that evaluation, and even bone on bone, even though I would probably, if it's severe degenerative joint disease, I would probably refer to a surgeon. In the meantime, there are plenty of conservative measures to help ease pain and also to prepare you for a successful outcome of
see,
surgery.
that's wonderful. This is really,
Yeah.
really great.
Right.
This is great.
So a lot of different types of pain relief is out there in terms of oral, topical. Physical therapy is crucial before and after surgery to try to strengthen up that muscular support around the problem area as much as possible.
Now, let me ask you, you mentioned Botox. Now, I thought Botox was for like wrinkles and that sort of thing.
So it's kind of a similar idea. What's a wrinkle? A wrinkle is a spastic muscle, muscle that's in spasm. The Botox relaxes that and it makes it smooth. Similarly, if a person's had a stroke, usually in the beginning they're very weak on one side. They may or may not be able to move their arm or leg at all. Usually a couple months down the line, one of the consequences of a stroke is that that side becomes tight and spastic. The muscles spasm.
I've seen it.
Yeah, exactly. And sometimes, it's okay, maybe they can put a bag on their arm and it helps them carry the bag. But a lot of the times it's very painful and their fingers can dig into their palm and it can cause skin breakdown and other issues and also can just prevent them from daily functioning that they were normally able to do in the past. So we would inject Botox into the muscle groups that are tight. So for example, like this, it would be the biceps would be one of the ones that's tight, and we would inject the biceps, and over a week or so it would relax a little bit.
No kidding.
Yeah.
I've been learning something here.
Absolutely, yeah.
You know,
Well, so
I
am I.
have
That's
and
terrific.
Doc knows this, I have a bad knee. And as I've gotten older, and I've told Doc this, I noticed that I don't have the balance I used to have when I was younger. And I needed to change a smoke alarm battery the other day, and I didn't feel very comfortable getting up on a chair, you know. Years ago, you could jump up in a chair and jump over the house and everything else, but that goes away
Yeah.
when you get older.
Yes, it does.
Well, yes and no, not necessarily. I getting older isn't equivalent to becoming bedbound and wheelchair bound. You should still be active and remain as independent as possible. If in such situations where you're getting older and you feel this loss of balance, there could be many different reasons for that. And part of an evaluation with me would be to go through your history, a full physical examination to kind of tease out which way it's going, and then there are many different avenues to exploration and treatment, including therapy. There's many different kinds of therapy. There is therapy specifically for balance and gait training and things like that. So
I think UH had a little seminar, Doc, where they tested your balance here several months ago in this hospital here, I believe. And a lot of people attended, But very interesting stuff.
Yeah, I mean, it's incredible. It's wonderful for our community to have access to this.
Sure.
Because, human nature being what it is, there's lots of people out there who may not even realize that there's something going on. I mean, if they fall, okay, well, why did I fall?
Right.
But they may not know, and if awareness increases, they're going to be paying attention. When people know that there's someplace they can go and actually can get help, that there may be a reason for what's going on, that it's a problem that can be solved, people tend to kind of tune into it a little bit more.
Sure, I agree.
And kind of see what's going on. And, in that case, when people are watching to see, well, gosh, am I able to move as well as I'd like? Do I have difficulty concentrating? Do I have difficulty with my balance? That kind of thing. And they get help early. In almost every case, it's better to intervene early than it is to wait and intervene later.
and prevent further complications down the road or reoccurrences down the road.
That's one of the things I wanted to ask you. You don't practice in Conneaut, correct?
No, so I'm actually in Geauga 4 days a week, and I'm in Geneva on Thursdays.
Geneva.
Oh, I didn't
Yeah,
realize that.
yeah,
You're in Geneva.
Yes.
Oh.
So 1 day a week I'm in Geneva.
That's a close ride.
Yeah,
Oh,
it's not
yeah.
so bad.
Oh, yeah. No, that's not so bad. Most of
I
the
had
time,
no idea.
when I talk to patients and tell them about, well, you have to go to Geneva, they say, you can just see they're relieved they don't have to
Yeah.
go to Cleveland.
Yeah, right.
Yeah.
Exactly.
Exactly. I had a patient who had an appointment with a physiatrist in downtown. It was a 45-minute drive for him, and Geauga was literally down the street from him, so he was very happy to have me on this side of town.
On this side of town. Oh, no, it's it's huge. It's huge. I mean, I'm just thinking, as I hear you describe the sort of services that you have available, I mean, I just think about the people that I see coming through our office who have no idea that this is available.
Right. This is all new to me.
Well, you see, and that's what, folks, that's what this show is about. That's what this show is about, is for our town, our little community, to know what kind of expertise is available and know that they can ask for it. You know, you can call Dr. Serels directly. You can call my office. You can call your primary care doctor's office, and anybody can get that all set up for you.
Absolutely.
It helps you to know that this is available. You know, you may be aware of it before your doctor even is.
And if you have any questions about any of this stuff, Dr. Bryant encouraged you to call him or email him.
Yes.
Number is 599-7640.
Yeah, you can just call. Karen at my office is expecting this, and you can just call, and it may not even have anything to do with me at all. Okay, you may want to call because you have a question about something unrelated. You may have a question about how do I get in touch with Dr. Serels, and she will give her number here. But we have it too, and so if it's just that we're acting as kind of a switching station to get you hooked up, that's something that we feel an obligation to provide. So.
Yeah, my office number is 440-285-7256.
440-285-7256. Right, and I think it's safe for me to say, you know, her office would welcome any calls, whether it's from your doctor, whether it's just from you. You know, if you just want to pick up and you want to come see her directly because you have something going on that you think she might be able to help with, you can call. You don't need somebody else to make the appointment for you.
So you don't need a reference from a doctor?
No.
Nope.
I could just call and say, hey, Dr. Anna, I got a bad knee. Will you check it out for me? You would do that.
Exactly.
Okay.
Yeah, see, and I think, you know, for a long time, that insurance companies were playing those kind of games.
Right.
You know, where there was a gatekeeper and all of that stuff. That's not and people still kind of think, well, I can't come unless my doctor. Well, that's not true. That's not how it works. So, yeah, you can call directly on your own without a referral.
That's right.
Yeah. Do you take care of patients with fibromyalgia?
I do.
Interesting subject. My sister has that, and she's pretty well debilitated with it. She's had it for years. Mainly, she's had it. I guess they didn't diagnose it years and years ago the right way because they didn't know that much about it, maybe back then. Now she's 57, 58 years old, and they finally got down to it. And she has to have something like an infusion shot, very expensive shot, once every couple months maybe. Does that sound right?
Yeah, there's unfortunately fibromyalgia is one of those that they don't know that much about yet, but they're learning more and more with each year. So, and there's unfortunately nothing yet that works automatically 100% all the time.
You're right. And what is it? I mean, why is it different than regular arthritis or whatever?
Well, that's what they're trying to figure out. What they're learning now is that it seems to be of autoimmune origin. So something in the body is not liking itself and is starting to attack these different systems in the body. And so that's how they're trying to go towards the medications from the autoimmune side of things. With some success. Sometimes, you know, it's just a matter of managing the pain symptoms and remaining active and being active in therapy and treating the symptoms as much as possible because there is no cure.
Yeah, unfortunately. I didn't notice that she was walking with a cane. When she came back home this past summer, she wasn't using a cane and she was walking pretty well. So there's some kind of treatment that she's getting that has certainly helped her.
Yeah.
And it was good to see, you know, your baby sister being able to get around again.
Yeah, that's good.
Yeah. What about rheumatoid arthritis? Can you treat that?
So with all of these diagnoses, for example, rheumatoid arthritis or Parkinson's disease, they would usually be diagnosed and treated by the rheumatologist or the neurologist. I wouldn't be prescribing the Parkinson's medications or the rheumatoid arthritis medications. What I would be doing is managing the consequences of those diseases. So if somebody is having pain in their hands or unable to do something that they used to be able to do with their hands, or somebody with Parkinson's is unable to walk properly and their balance is off and their gait is off, or they're having pain, I would help manage those issues, basically the things that are affecting their functioning, not the disease process itself. I'll leave that to the experts.
Okay.
That's a very important concept.
Mm-hmm.
And I think one of the take-home messages here is, okay, we'll just say you've been diagnosed with Parkinson's, okay? So you've seen your primary care physician, you've seen a neurologist, you've been placed on appropriate therapy, okay? And a lot of people say, they kind of have the impression, okay, that's it, I've done what I can do. They're treating it the best they can.
Right.
And what we're learning here today is, no, that's not the case. Sure, they're treating it the best they can, and you're on the best medical therapy and so on, but there's still consequences, and you don't have to live with those. You can do something about it, something effective. You can get some help with it.
Sure. Are these kind of diseases, say like rheumatoid arthritis, is that hereditary?
A lot of the times it is, yeah.
Is it really? Because my father had it.
Yeah.
And, I often wondered if we should be checked as kids.
Well, there's no studies that prove that the screening process is beneficial or that it would really change anything. Basically, what you would do is once you would start showing some symptoms, then they would start testing you
I
and
see.
see if you're positive for the
So far,
blood markers.
okay, I guess.
Yeah. So that's a good sign.
I think enough seasons have come and gone, Pat, that you're probably out of the woods.
Yeah, I think so. I think you're right. And I like your philosophy, Dr. Bryant, because, and you said this the last time we did an interview together a couple weeks ago, that we don't have to live with a lot of these problems and maladies that we have physically. There are things that the doctors in this day and age can do that they couldn't do 40, 30 years ago.
Well, there's no question about that.
Yeah.
And I think one of the things that's coming through to me most clearly from Dr. Serels is the importance of remaining active, the importance of being able to carry out your life.
Mm-hmm.
Without a lot of pain, with the minimum amount of restriction. But the idea is to stay active. And that's really important for a lot of reasons. I mean, obviously for physical health, and you and I have talked on this show many times about exercise and how important it is and so on. But it helps you to stay engaged in life.
Mm-hmm. Mm-hmm.
It helps you to get out and about, to interact with people, to do activities that enrich your life and that are fun and interesting and that kind of thing, as well as carry out responsibilities that you may have.
Absolutely.
But staying active is really important, and it sounds to me like a lot of what you do in a lot of different areas of medicine, different diagnoses and so on, is geared towards helping people maintain that activity.
And as much as independence as they possibly can.
Independence, absolutely.
I know, and I've told Doc. Doc is aware of this. My wife has a 96-year-old aunt who still goes out and sweeps, doesn't rake them, but she sweeps the leaves out of the driveway, goes to the store every day, and she goes, the key to life is staying active. I think it was, if you rest, you rust. So just keep moving,
Well,
It's
96, that's fantastic.
It is.
That's exactly what I try to tell my patients. Our bodies are filled with muscles everywhere. What's the job of a muscle? The job of the muscle is to move and to support the structures underneath it. When your muscle isn't moving, it becomes angry. It starts hurting. It goes into spasms and it atrophies. This is not the way it's supposed to be. For example, if you're in the hospital, just after 3 weeks of being in a hospital, you can lose up to 50% of your muscle mass. And you come out
In 3 weeks?
In 3 weeks, 50% of your muscle mass. the muscles aren't moving at all. What are they doing there? So they're just sitting there, they start to hurt, they become tight, and they shrink. So a lot of what I do is try to tell patients that there's a difference between safe pain and dangerous pain. For example, if you put your hand in the fire, it hurts. That's dangerous pain. That's important for you to move your hand away so you don't get burned. That's appropriate. But then there's safe pain. You have a pain, you've been evaluated, investigations have been done, and it's been deemed that there's nothing dangerous going on, and now you have to learn how to fight through that pain for a little bit and get back into moving, and then you will feel better.
I wanted to ask you too, for those out there that might be interested, what is the day that you're in Geneva?
Thursdays.
Thursdays.
That's great. Thanks
that
for
would be
bringing that up.
tomorrow. That would be
Tomorrow, yeah.
tomorrow. Okay. Right. Excellent. Excellent.
That's great. And I believe you told me that you did have occasion to meet a lot of the docs here in town.
Yeah, I've been going around with my physician liaisons, trying to meet as many family medicine practitioners and primary care physicians around the area as possible. Next step is to meet the orthopedic surgeons and neurologists in the area as well.
Excellent.
So if you bring up, if you ask your doctor here in town about Dr. Serels, they'll know who she is.
Hopefully, yeah.
Yeah.
They all have my cards.
Yeah.
So you went around and actually introduced yourself and everything?
Yeah.
That's great.
Well, that's it. That's UH.
That's great. That's a great policy.
That's what UH does. It's, it's good. It's obviously it's good for the health system to have patients to take care of, but in a community like ours, it's particularly helpful. It's particularly a service to the community, because otherwise people won't know.
Exactly.
People don't know. And she can have all the expertise in the world. If you don't know she's there, it's not going to help you.
Right. Exactly.
So.
Exactly. Very interesting stuff.
Oh,
I'm so
gosh, I
glad
learned
you
it.
came.
I really learned a lot.
I know.
This is terrific.
And I saw, actually, excuse me, I saw a write-up in the paper about you being, joining UH the other day, and I go, that's the gal that's going to be on the show with Dr. Bryant. And I'm so glad that Dr. Bryant had a chance to bring you in, introduce you to the community.
I'm glad I
I
came.
think it's very important.
Yeah, oh gosh. Well, I really am grateful to Dr. Serels for taking the time to come out to our town
No problem.
and talk
Thanks for
to
having
us.
me.
And I'd like to thank Don Watson for doing the show with us today. Don, we really appreciate it.
Did a good job.
Coming out,
Good
and
job.
to the city of Conneaut, which is making this program possible.
Yes, Cable Advisory Board has given their best wishes for this show to happen, and I think we have to give credit to Dr. Bryant for wanting to pursue this and get it on Channel 6 and 19. And I think it's a great thing for our town and community. And we'll be doing another one in a couple weeks.
Oh yes, the way things are set up, we do shows every 2 weeks, sort of like clockwork, and then they're aired in between times,
Right.
until we do the next one.
Right.
I'll just mention that on the next show, we're going to have somebody come in again, I think from Geauga, but this has to do with hospice and in-home care.
Okay.
And the amazing initiatives that UH is carrying out in those areas,
Very good.
and what's available to people. I mean, it's a tough subject, it's a difficult subject, but when people understand what's out there and what's available and what can be done, it's tremendous relief.
Looking forward to that.
So we'll be doing that on the next segment.
Well, again, Dr. Anna, I'm really glad to meet you.
No, you too.
And stay in touch with us. We hope you come back and see us again.
Yes, for sure. Thank
Yeah.
you so much for having me.
Okay.
All right, thank you. Okay, folks, until next time, I'm Pat Williams with Dr. Bryant and Dr. Anna Serels from UH.